Good evening, everybody. This is our third COVID-19 online educational program, and I'm Anton Pozniak. I'm a consultant physician at the Chelsea and Westminster Hospital and at the London School of Hygiene and Tropical Medicine. I'm very glad to welcome you today to this wonderful webinar where we're going to look at diagnosis, both virological and serological, and how that can be used in terms of our clinical work. So I'd like now just to introduce the program directors: Charles Boucher from the Erasmus Medical Center in the Netherlands, Daniel Karitskis, who you'll hear a bit more about later, from Harvard Medical School in the US, and Jonathan Shapiro from the Sheba Medical Center in Israel. Thank you to all of you for a wonderful input into this program, and as I say, it's already our third. I'd like now just to go through the agenda and our speakers. So we welcome back Anne-Geneviève Marcelin from the Hôpital-Pitié-Salpêtrière in Paris, France, and we have a new speaker now, Sanjad Kanjilal, and the two of them are going to cover viral diagnostics and types of assays, and Sanjad's going to talk about serological assays, including the comparison of those commonly used. And I must say, for myself, it's one of the commonest questions I'm asked about serological tests these days. Then Dan's going to look at the clinical and public health applications of COVID assays. I'm really looking forward to this because we hope it'll sort of untangle some of the puzzles that we have. And then we'll have a roundtable discussion. I'll now go through some of the learning objectives, which hopefully after attending this webinar, you'll recognize the different role of diagnostic technologies in this COVID-19 pandemic, have an understanding on the different diagnostic tools, and have some knowledge on the factors influencing their sensitivity and their specificity. So we can then reflect on the diagnostic challenges to monitor the COVID-19 pandemic. Now, no webinar would be worth its salt without a survey afterwards, so that you can tell us what you've thought of this webinar and how we may improve things in the future. I'd now like to acknowledge Roche. This edition of the COVID-19 online educational program is supported by an independent medical education grant from Roche, so thank you very much. We also have many people that have endorsed this program. I'd now like to move to introduce Anne-Geneviève Marcelin, who's a professor of medicine at the Sorbonne University in Paris and a clinical virologist at the Pitié-Salpêtrière Hospital. She's head of a research team there from INSERM, looking at therapeutic strategies for HIV infection. And she's got a lot of research interests, including the mechanism of resistance to antivirals, and she's on WHO steering groups. So it's with great pleasure I'm going to introduce her to talk to us about the virological diagnosis of SARS-CoV-2. Thank you very much, Anne-Geneviève.
So good evening. My name is Anne-Geneviève Marcelin. I'm a professor of virology in Pitié-Salpêtrière Hospital in Paris. And I will speak about the virologic diagnostic of SARS-CoV-2. So here are my disclosures. During my presentation, I will speak about first the virus, then the viral diagnostics. I will speak mainly about RNA test diagnostics with the assays performance, the kinetic of this marker, the viral load, and where we can find the virus RNA in the body fluids and tissues. Then I will finish with the antigen detection, and then by a conclusion. As you know, in late December 2019, cases of severe pneumonia were reported. They were epidemiologically associated with the Yunnan seafood market in Wuhan in China. And an unknown etiologic agent has been identified to be related to this severe pneumonia. So this etiologic agent is SARS-CoV-2. This is a beta coronavirus. This is an enveloped virus, and you can see that there is a spike protein at the surface. This protein mediates attachment to host cell. The genome of the virus is a positive sense single-strand RNA of 30 kilobases, and you have here all the gene along the RNA. Phylogenetic analysis of whole genome sequences showed that this virus has a 88% identity with bat-derived coronaviruses. And it has been shown also that this virus is approximately 79% identical with SARS-CoV-2 and about 50% with MERS coronavirus. The test to detect the COVID-19 can be divided into two main categories. First, molecular diagnostic test. This test will detect the presence of the virus, and they help to identify people who are infected. There are other tests, the serological test, that will detect the immune response to the virus, and they allow the detection of people who are already had the infection and develop antibodies. And I will speak only in my presentation about molecular diagnostic test. So RT-PCR is the most commonly used and reliable test for diagnosis of COVID-19. This test is performed on nasopharyngeal swabs or other upper respiratory tract specimens, including throat swab. And there is a variety of RNA genes that are targeted by different manufacturers. And the most tests target one or more gene in the envelope, the nucleocapsid, spike protein, RNA, RDRP, and ORF genes. So this is one of the first assays that has been developed by Hôpital La Charité in Berlin. And they established and validated a diagnostic workflow for this virus screening and then a specific confirmation. They recommend to use first the e-gene assay here as a first-line screening tool, followed by a confirmatory testing in the RDRP gene then. So this laboratory-based molecular testing are performed after specimen collection. Then the samples undergo RNA extraction, followed by a qualitative RT-PCR for target detection. And the results are available within 3 or 4 hours. In April 2002, there were 28 commercial SARS-CoV-2 in vitro diagnostic assays that are approved by the FDA. So there are commercial assays that are available. And there are also some point-of-care molecular diagnostics. And these assays have low complexity and rapid techniques. And the results are available within approximately 1 hour. On this slide, we have the comparison of 7 commercially available RT-PCR kits for the detection of SARS-CoV-2. And you can see that all these RT kits performed satisfactorily. Overall, the PCR efficiency is about 96%, and the lower quantification, the lower level of quantification varied from 3.8 to 23 copies per ml. So on this slide, you have only 7 commercially RT kits, but there are a number of other commercial kits that are available and are also approved by CE or FDA. So these tests are generally very sensitive and specific. So for example, if an RT-PCR is positive, the result is most likely correct. And the only case of false positive could be happening if a non-positive sample is contaminated by viral material during test processing, for instance. False negative results are also possible, but are most frequently the result of a wrong patient sampling, up to 30%. For example, swabs are not pushed far enough in the patient's nasopharynx, for instance, or for example, also an inadequate time of sampling, and I will discuss that further. So this is a very nice figure published in JAMA, and on this slide you have in blue the results of nasopharyngeal Schwab's PCR, and in pink the bronchoalveolar lavage or sputum curve for PCR. So as you can see, in most individuals with symptomatic COVID-19 infection, viral RNA in the nasopharyngeal swab, as measured by a CT becomes detectable as early as day 1 of symptoms and peaks within the first week of symptom onset. And this positivity starts to decline by week 3 and subsequently becomes undetectable. It has been shown that there is a relationship between the viral load and the disease severity. In this prospective study, the authors look at the RT-PCR in the nasopharyngeal samples from 30 severe cases and 46 mild cases. And I remind you that the CT is a number of replication cycles required to produce a fluorescent signal, and lower CT values representing higher viral RNA loads. So as you can see, the mean viral load of severe cases in red are higher than the mean viral load of mild cases, approximately around 60 times higher. And it is interestingly to note that in 90% of mild cases, they were repeatedly testing negative on RT-PCR by day 10 post-onset. However, all severe cases here were still tested positive at or beyond day 10 post-onset. So patients with severe COVID-19 tend to have a high viral load and a long virus shedding period. And PCR positivity may persist beyond 3 weeks after illness onset, when most mild cases will yield negative results. However, a positive PCR result reflects only the detection of viral RNA and does not necessarily indicate presence of viable virus. In some cases, viral RNA has been detected by RT-PCR even beyond week 6 following the first positive test. And a few cases have also been reported positive after 2 consecutive negative PCR tests performed 24 hours apart. However, it is unclear if this is a testing error, a reinfection, or a reactivation. So now if we look at the timeline of PCR positivity between different specimens, different specimens, in this prospective study on COVID-19 patients, you can see that the median duration of RNA shedding were 12 days in nasopharyngeal swab, 19 days in sputum, and 18 days in stools. So the PCR positivity declines more slowly in sputum and may still be positive after nasopharyngeal swabs are negative. As I said before, the presence of RNA does not mean necessarily that the virus is viable. And in this detailed virological analysis of 9 cases, they provide proof of activity of active virus replication in upper respiratory tract tissues. They showed that the pharyngeal virus shedding was very high during the first week of symptoms, like in the other study. And it was interesting, the results were very interesting because infectious virus was isolated in 83% of samples during the first days from throat and lung derived samples, but never after. And they were not able to isolate virus from stool samples. So these results correlates with the decline of infectivity beyond the first week. So if we look at the different result between respiratory samples in this retrospective study, where 19% of patients had severe illness, you can see that the bronchoalveolar lavage fluid showed the highest positive rates in 93% of cases, followed by sputum in 72% of cases, and then nasal swabs in 63% of cases and 32% in the pharyngeal swabs. It has been shown also that a higher viral load has been identified in sputum than in throat swabs. Here you can see that the viral load in sputum was higher in throat than nasal swabs. And they showed also that the peak of viral load was observed after 5 or 6 days after symptoms onset. So now, if we speak about the viral antigen detection, this is another way to detect the virus presence. These tests are based on lateral flow immunoassay. They could be performed using swabs, similar to those currently used in RT-PCR. They would be quick to run, less than 15 minutes, and could be used at the point of care, so no need for a lab. However, they still require to have their performance assessed. For example, in April, there were 5 viral antigen tests that have received a CE marking. And I know that one is now registered by the FDA. However, they need, in this test, need high enough presence of surface proteins to be detectable. So that means that they have a higher chance of false negative than PCR test. So we absolutely need clear guidance on correct interpretation if these tests are implemented. So in conclusions, RT-PCR is the recommended test for a diagnosis of COVID-19. This test is recommended for symptomatic but also for close contacts in order to apply the strategy of testing, tracking, and tracing. And these tests are recommended to be performed on nasopharyngeal swabs mainly. And the tests are, these RT-PCR tests can be semi-automated, or there is also some high throughput systems that can perform for example, 500 tests per day. And there are also some point of care systems. And all these tests could allow results between 1 hour and 4 hours. These tests are generally very sensitive and specific. However, the specificity can depend on quality, the type of samples, and the disease stage, as you show on the results I presented before. The RT-PCR test is detectable as early as day 1 of symptoms. And the peak of the detection occur within the first week of symptom onset. A longer shading of RT-PCR has been observed in sputum and stools than in nasopharyngeal swabs. And it has been shown also that patients with severe disease tend to have a higher viral load and a long virus shedding period. For the antigen detections, we need further evaluations to be implemented with clear guidance on correct interpretation. So I would like to thank you for your attention, and I will be happy to answer to your questions.
Thank you so much, Anne-Geneviève. I always learn so much from your talks. I just wanted to ask you, I know that these nasopharyngeal swabs are very uncomfortable, and I just wondered about the use of saliva, which would be easier to do a test, doing salivary tests. What's sort of utility of those?
Yeah, there are some studies now showing that it is possible to perform a RT-PCR test in saliva. However, this study is still performed on very few samples and few comparisons. So, for example, in France, to date, this is not the recommended test for SARS-CoV-2 detection. But yes, if it's confirmed that this could be an alternative, it could be very interesting, because it's very easy to get saliva from patients, and to yes, I think it's a very interesting option, but that needs further evaluation to confirm the reliability of this sampling.
Yeah, it seems like we're in a little bit of a watershed for both the antigen test and these other respiratory secretions. And hopefully in a few weeks, we may have some more guidance on that. But we've had quite a few questions actually from people saying, can these COVID tests be used on standard systems already in place in the labs? How hard is it to set them up?
Yes, en fait, yes. I think to choose a test that you want, that you would like to implement in your lab, you have to first see what machine you have, which extractor you have, and which amplificator you have, and because there are a number of tests that are available, and it's very easy to find the right test that is well adapted to your lab. If you have a big machine, if you have, for example, a Roche Cobas, you have already this machine, you can implement the Cobas assay. If you have an Serologic platform, you can implement the Serologic test. And if you have not this machine, you have a number of options to make first the extraction and then the RT-PCR. There are some kits providing some manufacturers with only the amplification. And so I think you have to look at the facilities you have in your lab and to choose the right method regarding that.
Oh, well, thank you very much indeed. And we're going to ask you some more questions, so don't go away in the round table. And now, thank you. We're now going to move to our next speaker, who's Dr. Sanjat Kanjilal. He's a lecturer in the Department of Population Medicine at the Harvard Pilgrim Healthcare Institute, and he works in clinical microbiology at the Brigham and Women's Hospital in the USA, and is an infectious disease physician. So it's fantastic background, but the real thing now he's been working on is research on improving diagnostics for bacterial and viral infections, including the SARS-CoV-2. So, and he's been leading efforts to develop and scale up diagnostic testings for SARS-CoV-2 at the hospital, at the Brigham and Women's. And he's going to talk to us about serological assays, including comparison of those usually used. And I'm going to listen with extra enthusiasm because, as I said at the beginning, this is something that so many people ask me about. And so I'm really glad to be able to listen to this talk today. Over to you now, Sanjat.
Hi, everyone. My name is Dr. Kanjilal. I am an Associate Medical Director of Microbiology at the Brigham and Women's Hospital at Harvard Medical School and a lecturer in the Department of Population Medicine. And I'm going to talk to you today about a broad overview of serologic testing for SARS-CoV-2. And I have no disclosures to report. So I'd like to start this talk by first addressing a very common misconception among people when they think about serologic tests versus PCR tests, which were talked about in another section of this talk. And the fundamental difference is that molecular diagnostics are actually looking for the actual virus itself, whereas serologic assays are looking for the humoral or the antibody immune response to a virus. And the table below highlights some of the differences between the two tests. So for serologies, the target, as I said, was looking at the antibodies to the virus, whereas molecular tests such as PCR are looking for viral nucleic acid or viral antigens or proteins. And in general, serologic tests are run on blood, and separated into serum or plasma, whereas molecular tests are run on upper and lower respiratory tract specimens, which are generally collected using nasopharyngeal swabs or other such collection mechanisms. The use for serologies at the current moment are, one, to diagnose active infection with the caveat that this is an off-label use, but it can help in cases where PCR is negative, symptoms began some time ago, roughly at least 7 days, and suspicion for clinical infection with COVID is still very high. Primarily the use case serologies right now, however, will be to determine prior infection, and there are many other potential use cases that are on the horizon but not ready at the current moment. PCR, on the other hand, really is solely used to diagnose active infection right now. And the types of serologies right now include ELISA assays, which I'll talk about, neutralization assays, and the molecular tests really focus on mostly PCR, but also include loop-mediated and isothermal amplification assays, CRISPR diagnostics, and more recently, some antigen detection assays. So a critical component of testing for SARS-CoV-2 relies on understanding where in the illness course the patient is with respect to the onset of symptoms. And so this is just a schematic of that is commonly used for describing this phenomenon. And the choice of which type of assay to use depends heavily on where the person is along this timeline. And so within the first 0 to roughly 7 days of illness, the levels of RNA in active infection are quite high and drop off precipitously as the immune response begins to pick up around day 4 or day 5. And that goes the same for viral antigens. And in fact, the peak levels of RNA may actually occur before symptoms occur in the week before and start downtrending once symptoms appear. As shown here, roughly on day 4 or day 5 are when antibodies begin to appear, and IgM is the first isotype to appear slightly before IgG antibodies. IgM then peaks roughly between day 7 and 14 before declining roughly over the course of the next couple of weeks. IgG antibodies appear slightly after IgM, continue to rise through the first 2 weeks of infection, and then plateau and persist for at least 6 to 8 weeks, according to the latest studies, probably longer, although we haven't had enough follow-up time to determine that. And so just to summarize what was shown in the previous slide, in the first 5 to 7 days post-onset of symptoms, PCR or another molecular diagnostic is really the test of choice because you have plentiful virus to actually detect. But starting at around 7 days onwards, antibodies become detectable and can certainly aid in the diagnosis of active infection in cases where the PCR is negative. But at around 2 to 3 weeks post-onset of symptoms, serologic tests become more useful than PCR tests, where the probability of false negativity with the PCR rises precipitously. And in patients without symptoms, which recently has been reported to be as high as 80% of people with SARS-CoV-2 infection, serologies may represent likely the only means of diagnosing prior or even active infection. And as shown, IgM rises slightly before the IgG, wanes roughly by week 3, whereas IgG remains high starting around week 2 and plateaus across the time course for at least 6, probably longer weeks post-infection. So there are multiple types of assays that are currently in circulation. And they can fall roughly into 3 broad categories, and I'll show each of those right here. So the first one are what we call rapid diagnostic tests, which are also, in this instance, referred to as lateral flow assays. And the diagram here is shown on the right. It's similar to a pregnancy test where a sample is placed in this diagram on the left-hand side of a test strip, and then through capillary action moves right through the test. As the antibodies, if they're present in a patient's serum, cross the conjugation pad, it will come in contact with viral antigens that are conjugated to gold particles. And if present, they'll bind and be carried forward to either the M line, where IgM antibodies to humans are located, or the G line, where anti-human IgG antibodies are located. And then the last line is just a control line to make sure that the reaction proceeded as expected. And so a positive IgM test will have a line at the M spot and one at the control spot, whereas a positive IgG test will have one at the G line and the control line. And in patients who have both antibodies, all 3 lines should appear. Below that, I show a very commonly used assay for serologic diagnosis called an enzyme-linked immunosorbent assay, or an ELISA. And there are multiple flavors of this type of assay. I'm showing one on the right here, where if you can imagine that cylinder is a well on a plate, and on the bottom of that are coded antigens from the virus that are fixed to the bottom of the plate in a solid state. Again, the patient's serum is added to the well, and if antibodies are present, they will bind the antigen that is located on the bottom of the plate. And then a secondary antibody is added, which is specific to the primary antibody, which binds to the antigen. And that secondary antibody is conjugated to an enzyme. And when the substrate of that enzyme is added to the well, a color change will appear that can be detected. And this test can be qualitative or also can be quantitative. The last type of assay that is on the market right now is called a chemiluminescent assay. And the principle is similar to an ELISA. However, it's instead of being in a solid phase, it's actually in a liquid phase. And so this is the basis of the Roche-Cobas SARS-CoV-2 antibody assay that I'm showing here. And the principle is shown starting on the left-hand side. Again, a patient's sample containing antibodies to SARS-CoV-2 is added to a suspension that contains antigens from the virus, in this case, the nucleocapsid antigen, in 2 forms. One form of the antigen is bound to a ruthenium molecule, and the other one is bound to biotin. After a period of incubation, magnetic beads that are coated in streptavidin are added to the sample, and any antibody that is bound to nucleocapsid that has the biotin on it will bind the streptavidin-coated magnetic bead. And again, after a certain period of incubation, a magnetic field is applied to this complex, and any beads that are attached to this complex will be fixed, whereas remaining non-specific antibodies will be washed off. And then lastly, an electric field is applied to it such that electrons on the ruthenium molecule will be excited and will emit certain photons of light that can then be measured in a luminescent assay. And so this provides also quantitative measurements. So looking at these three tests side by side, the RDT being the lateral flow assay, or the LFAs, the ELISAs, the chemiluminescent assays in the third column, and on the right are the gold standard neutralization assays. Results for the lateral flow assays are qualitative. They're either positive or they're negative. ELISAs and chemiluminescent assays can be qualitative or semi or fully quantitative, whereas neutralization assays are a quantitative test. The turnaround time here is roughly just minutes with the RDTs. ELISAs typically take a couple of hours. The chemiluminescent assays can be as fast as 18 minutes for the Roche, but generally can take a couple of hours as well. And neutralization assays require days because you are incubating live virus with cells. The throughput of the RDT is relatively low because you can only do one patient per test. For ELISAs, they're considered medium throughput on the order of several hundred a day. And the chemiluminescent assays are high throughput where we can do up to thousands a day. And neutralization assays are very low throughput. They can only do several a day. For the deployment of RDTs, these are really meant to be at the point of care, whereas the ELISAs and the chemiluminescent assays are lab-based. And neutralization assays are really reference lab-based because they involve, again, dealing with live virus, which requires biosafety level 3 containment procedures. Only one assay, which is the neutralization assay, actually detects for the function of the antibodies, which is why they're considered one of the gold standards. And compared to the sensitivity of ELISA, the RDTs typically have lower sensitivity, and the chemiluminescent assays, based on their technological advances, tend to have higher sensitivity compared to the ELISA. And so what targets are these tests actually looking for? This is just a quick schematic of the virion for SARS-CoV-2. This has been shown before, but to go over quickly, the two immunogens, which are the proteins which humans mount an antibody response to, are the nucleocapsid proteins shown here and labeled as N, and the spike protein shown here, which is what gives coronavirus its name. The function of the nucleocapsid protein is both structural as well as non-structural, but primarily it encloses the viral nucleic acid here, whereas the spike protein is responsible for binding to receptors on human cells that give it the virus its tropism. And the spike protein itself, it has three domains really, the S1 and S2 domains, and then one called the receptor binding domain. And the advantages of the N protein are that it's more plentiful typically in infection and can be relatively easy to produce in large quantities in the lab. However, because it's shared more closely with other related coronaviruses, may be somewhat less specific than the spike protein. And RBD, or the receptor binding domain in particular. The disadvantage of the spike protein is that it's found in lower quantities and can be a little bit harder to produce in the lab. Thus, the choice of assay should depend in part on whether you wish to rule in disease by choosing an assay that is highly specific, such as one that targets the spike protein, or ruling out disease by choosing an assay that's highly sensitive, in other words, targeting the N protein. So there are many assays out there currently, several hundred in fact are in circulation, of which only a few are actually approved by the FDA under the emergency use authorization. This is a table of just several of them, courtesy of Dr. Khalid Alter. And the performance of these tests varies very widely. And many of you may have seen these headlines across major news outlets discussing this problem. So the one on the right was from the New York Times, discussing an article that we'll go into shortly, but looked at variability across lateral flow assays and ELISAs. And then the one on the left just appeared several days ago in Forbes magazine, talking about false positivity rates in areas where prevalence for COVID is less than 5%. So unless your test specificity is very high, on the order of 99%, your false positivity rate can be quite high. And so to dive into some of the data briefly here, this is an article that appeared on medRxiv a couple of weeks ago from a group out of the University of California, San Francisco, and Massachusetts General Hospital, which looked at 10 different lateral flow assays and 2 ELISAs assays. And these are some of the results that are from this paper. And so this is looking at only the lateral flow assays, and along the rows here correspond to whether the assay is an IgM assay, the combined performance of IgM or IgG, and IgG specific performance. The y-axis here is looking at the rate of positive samples, and then the columns here correspond to days of onset from symptoms. And so right off the bat, you can see that very early on, the sensitivity of this assay is quite low, which is what we expect based on the antibody response, and then rises over time, peaking roughly at roughly 3 weeks after the infection started. But what's really striking is among these 10 different lateral flow assays, this is a linear scale, is quite a lot of variability, particularly up to 30 to 40% variability depending on which assay you use. And these target various, either the N protein or the spike protein. And when looking at the specificity, again, you can see here, while most of them are above 80%, that is not acceptable specificity when the prevalence of the disease is quite low. And the variability, again, between the different lateral flow assays is quite high. And when you actually look at this heat map on the left-hand side here, you can see that a patient sample, when run on one assay, may have very different results when run on a different assay. And so overall agreement here ranges somewhere between 75% and the high 90%. It gives you a sense of the complexity that if you were to actually receive tests from one patient on one of these assays and run it on another assay, it can be hard to predict what the results are going to actually be. And in general, there are many complexities in the interpretation, and as these assays, more and more assays begin to hit approval on the market, it's very important to take a critical look at the quality of the validation that was used to bring the assay to clinical use. And so some points to consider are: one, did the validation study include patients' serum that were infected by the endemic coronaviruses, ones that are in common circulation throughout the world, and in fact, people have antibodies to, the majority of the population have antibodies to it already. And you're really looking here for cross-reactivity between the assay that you're looking at and these other more innocuous coronaviruses. Does the validation study assess the time of the test relative to the time of symptom onset? Because the numbers that are given really depend on that time differential. Does the validation study assess the severity of illness or the immune status of the patient, which both can modulate the degree of positivity for the test? Does it assess for standard interfering substances that can block the performance of the test? And does it assess for non-coronavirus cross-reactivity to other viruses that produce very polyclonal antibodies, such as the Epstein-Barr virus, or other autoimmune factors, such as rheumatoid factor, that can cause false positivity as well? And then critically, it's very important to try to suss out what the quality of the reference comparator is that the validation study used to determine the assay's positive predictive agreement or negative predictive agreement, which are really the terms we use for sensitivity and specificity when there is no established gold standard to compare against. So all of these factors really should be taken into account, and can lead to quite a bit of confusion in terms of assay interpretation. And so I just want to walk you through several different possibilities for what happens when you get a positive SARS coronavirus 2 antibody result on a patient. The first thing to do is assess your level of clinical suspicion, whether it's high or low. And then the next thing to do is first determine whether they are symptomatic, previously symptomatic, or asymptomatic. So going down the pathway of high clinical suspicion right now, and if they're currently symptomatic, then it's probably safe to say that a positive antibody test will likely signify that the patient has an active infection, regardless of whether it's IgM or IgG, depending on the onset of symptoms, because both arise roughly at the same time early on. If you have a high clinical suspicion and they were previously symptomatic but currently asymptomatic, it is possible that they have recovered from SARS-CoV-2 infection. And if you have high clinical suspicion and they're asymptomatic, because 80% of people don't have symptoms at all, it is possible that they still have active infection and you need to confirm with the PCR test, or that they have fully recovered and there's no way to really distinguish between the two. Now, if we're looking at low clinical suspicion and they're currently symptomatic, then it's possible that this test has provided a false positive result, which again gets to the issue of having a test run on asymptomatic people in a low prevalence situation. However, there are plenty of stories of people being diagnosed with SARS-CoV-2 in the past or currently that have surprised the clinical teams. And so it is possible that if they are symptomatic, even in low clinical suspicion that they actually do have active infection, you'd be obligated to get a PCR test to confirm or rule out that. If they were previously symptomatic, it could also still be a false positive result, or it could represent that they have recovered from an infection in the past that was not detected. And then lastly, in low clinical suspicion, asymptomatic people, these folks really should not be tested for serologies to SARS-CoV-2 because, again, for reasons of having low prevalence, it is possible that you have a significant chance of receiving a false positive result. However, all of these different pathways are much more nuanced than what I'm actually showing here. I have to take into account the clinical status of the patient, time from onset of symptoms, and many other factors, and uncertainty in the sensitivity of the PCR alongside all of this. And so to me, the perfect serologic test is one that has greater than 90% sensitivity after at least 7 days of symptom onset, has at least greater than 99% specificity compared to a very broad validation cohort that I described in the earlier slide, one that would provide rapid turnaround and high capacity on a high capacity instrument, can be lab or point of care, depending on the use case for this assay, provides quantitative results where we can use to compare trends and compare across patients, differentiates IgM from IgG and IgA, and I think above all, most importantly, the perfect serological test chooses a target where quantitative levels actually correlate with protective immunity. And so while at the current moment, we can probably check off the first 4 or 5 of these different boxes with a single assay, none of the assays that are currently in use right now are known to correlate with protective immunity, or at least been shown definitively to do that. So therefore, we are still waiting on the perfect serologic test, and that will take at least several months more work efforts to determine what those correlates are. So lastly, the main takeaways are that serologies are absolutely a critical part of controlling the COVID-19 pandemic. As Dr. Kritzis will talk about, they serve many different roles. Currently, they serve the role of diagnosing potentially as an adjunct for active infection, but also determining prior exposure. There are many different types of assays that target different viral proteins and have different performance characteristics and different use cases. And it's very important that providers who use these tests try to get a sense of what those different characteristics are. And lastly, that test interpretation should be done very thoughtfully in order to prevent erroneous medical decision-making based on assumptions that may or may not hold for this particular assay. So thank you very much for your time.
Thanks so much, Sanjat. That was a really interesting talk, and actually it's focused some of my ideas. But I'm a little bit obsessed with saliva today. So what about salivary samples for antibody testing? There are some out there. Are they better than doing point of care blood?
Yeah, I think the studies are quite preliminary in that area, but there is some promise, especially in the detection of IgA, which tends to appear perhaps even earlier than IgM in the saliva. As you know, it's a secretory antibody. And so there's intense work going on using some next generation platforms that are extremely sensitive down to the level of single molecules to be able to detect IgA in saliva, perhaps at the same time or even earlier than PCR. I mean, they're a ways from the market, but there's intense activity on that. specific point. And that would really be a game changer.
Okay, fantastic. Another question that's intriguing me is that, and I'm from an HIV background where HIV mutates a lot. If there are mutations in the spike protein and you have an assay for the spike protein, could that give you a false negative on the assay?
That's a good question. I think in theory, yes. In reality, the RNA-dependent RNA polymerase for coronavirus is less error-prone than it is for HIV. And so, although I don't think there's definitive evidence yet for this phenomenon, I would be less concerned about that than, say, for HIV.
Mm-hmm. And I just want to get this right. Imagine I'm a healthcare worker and I want to be tested, and I get an antibody test that's positive. You'd recommend that actually I have a swab before telling everybody I'm fine and I'm immune if I've been completely asymptomatic.
It's an area of controversy. Yeah, I think actually the pendulum is swinging away now from PCR swabs, but it really depends on your comfort level with interpreting these analyses. And so I think right now there's data to show that the viability of virus and the ability to transmit drops from the days of symptom onset, and that may actually be a better marker for when to retest using a molecular diagnostic in the setting of a positive serology. But I think it should be still, at this early stage, evaluated on a case-by-case basis. And so I can't give you a definitive answer to your question.
Thanks. Well, that will take us into the next talk, actually. And it's so thanks very much. And we're going to get you back for the round table. We have lots of questions. So, so please stand by. And it's with great pleasure that I'm going to introduce Professor Daniel Kuritzkis from Harvard Medical School in Boston. He's part of the faculty, and he's now going to talk about the clinical and public health applications of COVID assays. Dan, I'm looking forward to this one too. Thank you.
Hello, I'm Dr. Daniel Kuritzkis from the Division of Infectious Diseases at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. You've heard excellent talks by Professor Anne-Geneviève Marcelin and my colleague, Dr. Sanjat Kanjilal, on the basis of molecular testing for detecting SARS-CoV-2 and the antibody testing for diagnosing COVID-19. In my talk, I'd like to place both of those presentations into a more clinical and public health context in terms of how can we actually apply these assays in the clinical setting. I have no relevant disclosures related to this talk. So there are a number of ways in which the virologic assays for detecting SARS-CoV-2 itself might be used clinically. These include diagnosing COVID-19, demonstrating clearance of COVID-19 in people recovering from the disease, screening patients on admission to the hospital, screening in specific patients who may be undergoing procedures that are likely to generate aerosols in order to protect the healthcare workers performing those procedures, and potentially in certain settings, screening employees. So let me discuss each of these in sequence. The diagnosis of COVID-19 has really depended up until now on the use of these molecular tests, particularly the use of nasopharyngeal or oropharyngeal swabs. And as discussed, one can use other sample types such as saliva and, of course, tracheal aspirates or sputum when available. These tests have high sensitivity and specificity, although certain rapid tests may be less sensitive than the classic PCR-based assays in certain settings. Nasopharyngeal swabs, however, can become negative later in disease, particularly in patients with prolonged infection where pneumonia comes to predominate. And in those circumstances, if a diagnosis has not yet been established when the patient presents with pneumonia and potentially respiratory failure, using sputum or tracheal aspirates if the patient requires intubation and mechanical ventilation can be a very valuable adjunct to nasopharyngeal or oral pharyngeal testing. There's much less value in performing quantitative testing on the clinical side. That it really remains a research tool. There are no validated quantitative assays, as was discussed, although one can infer something about the relative virus load by knowing how many PCR cycles were needed for the sample to become positive. And although a number of studies are now showing that certain individuals, particularly those with more severe disease, may manifest viremia with SARS-CoV-2, there's really no clinical role at present for testing for virus in the plasma. Much more controversial is the use of SARS-CoV-2 PCR testing for demonstrating clearance of COVID-19. In the United States, the Centers for Disease Control and Prevention provide guidance on two different paths for return to work for healthcare providers who have become ill with COVID-19. One path is symptom-based, and the other is test-based. For the symptom-based strategy, workers are excluded from returning to work until at least 3 days have passed since they have recovered from any symptoms, including fever, and that means being afebrile without having to use antipyretics such as acetaminophen, and improvement in their respiratory symptoms. And at least 10 days have to have passed since the original onset of their symptoms. However, there's a parallel pathway which requires demonstration that the individual has resolved their COVID-19 by demonstrating clearance of SARS-CoV-2 by nasopharyngeal swab testing. This is the test-based strategy that first requires, of course, resolution of fever and respiratory symptoms, but also then requires negative results using an approved COVID-19 molecular test for detecting a viral RNA. This existence of these parallel pathways leads to a certain amount of confusion. So, for example, at our own hospital, people who have become ill and are outpatient can be considered free of COVID-19 if they meet the symptom-based strategy. However, for inpatients, we still require demonstration of clearance of COVID-19 by a molecular test before we can remove them from strict respiratory precautions. We know, however, from a series of very well-done epidemiologic studies that, in fact, the transmissibility of COVID-19 drops dramatically after the first several days of illness. This left panel here shows the model by He et al., published about a month ago in Nature Medicine, demonstrating that the greatest period of infectivity and transmissibility is in the 2 to 3 days prior to the onset of symptoms. And by a week after symptom onset, there is essentially no risk of transmission. Now, this model is validated by these observational data from Chung et al., published recently in JAMA Internal Medicine. They followed nearly 3,000 close contacts of COVID-19 cases and demonstrated both for all contacts overall, as well as for close contacts in the household or family, that the transmissibility in terms of the attack rate was greatest in the first several days prior to symptom onset and in the immediate days following the onset of symptoms, but essentially dropped to zero by 1 week after symptom onset. And this is regardless of whether people remain COVID-2 positive by nasopharyngeal swab testing. So we really don't understand the mechanism of that persistent positivity, but it does raise the question of the value of continuing to test people and to use clearance of COVID-2 as a clearance of SARS-CoV-2 or COVID-19 as a benchmark for either a return to work, release from respiratory precautions, or release from quarantine. Now, many hospitals here in the United States are now screening all patients on admission to the hospital in order to be able to triage those patients who need to be placed into isolation and strict respiratory precautions, and those who can be handled with what are now standard respiratory precautions, that is just use of a surgical mask on the part of the healthcare team. Similarly, women coming into the labor and delivery ward are being screened, although in our setting we are now finding an extremely low rate of positivity among such women, not zero yet, but very low. And there's a great deal of interest in pre-admission screening or pre-procedure screening of patients who are requiring aerosol-generating procedures. This may include all surgeries because of the concern for aerosolization during intubation for anesthesia, individuals undergoing upper endoscopy, as well as transesophageal echocardiography, which is very much like an upper endoscopy in some respects, and people undergoing otolaryngology or ear, nose, and throat procedures, where obviously you're working in the oropharynx or the nasopharynx. Left out of this is actually dental care, which is somewhat of a surprise. And I think that relates to the fact that most dental practices are not closely linked to diagnostic labs. But clearly, providing dental care is very likely to be an aerosol generating procedure. Yet there haven't been clear guidelines suggesting that individuals coming in for dental hygiene visits or to have restorative work on their teeth performed should first be cleared by having a negative SARS-CoV-2 test. What about screening in other settings? There's been a lot of discussion, but certainly no consensus about whether employees coming back to a workplace, such as an office or a school setting, for example, should be screened prior to being allowed to return to work. There's even been a considerable discussion about the use of testing in order to allow contact sports like American football or soccer or basketball, where there's really very close contact between team members before people can be allowed to resume practice or resume play, and then potentially having them live essentially quarantined in a bubble among the team members so as not to risk introduction of SARS-CoV-2 into the group until after the games or the season is ended. Not certain how practical that's going to be. Similarly, many schools, colleges, and universities are discussing whether or not to have students tested on return to campus in the fall. And quite a few chronic care facilities, nursing homes, skilled nursing facilities, rehab facilities are requiring, in some circumstances, demonstration that the patient is free of COVID-19 before accepting them into transfer. The use of testing in all of these situations begs the question, if you are testing, then how frequently will you test? Just because an individual is declared COVID-19 free and able to return to work doesn't mean that they will necessarily remain free of COVID-19 in the subsequent weeks and months. Well, what about public health applications of virologic tests? Here, I think the principal use and the greatest importance is going to be in contact tracing. That allows the identification of asymptomatic contacts of cases who may be shedding virus but are unaware of their infection status. And this is really going to be essential as we relax the social distancing guidelines and return to work and return to a more normal society in order to be able to rapidly quarantine individuals who have been exposed and who may now be carrying virus and prevent the occurrence of multiple resurgent outbreaks in the coming months. Again, whether to use these tests to allow someone to be released from quarantine has the same concerns as using testing to declare somebody free of COVID-19 after illness because of the prolonged carriage of virus in some circumstances without evidence of prolonged infectivity. But in order for contact tracing to be able to use testing effectively, it's really going to be essential to have rapid point of care tests with a very rapid turnaround time in order to make this approach practical and scalable on a large population basis. Well, let's talk now about the clinical application of serologic tests for COVID-19. And there are three circumstances where these might be used, not all of them necessarily appropriate. One is for primary diagnosis, the second for retrospective diagnosis, And the third is the question of allowing people to return to work. Serologic diagnosis of COVID-19 harks back to a previous era of viral diagnostics before we had molecular tools, where diagnosing a viral infection typically required the access to paired sera, acute and convalescent serum, showing a rise in antibody titer. And there are occasional patients who may have a clinical syndrome that is strongly suggestive of COVID-19, but are negative for by PCR testing for SARS-CoV-2, especially if the only samples available are nasopharyngeal swabs. And in that setting, an IgM or an IgG might be useful if obtained at least 7 days from the onset of symptoms in order to make a diagnosis. In some platforms, an IgA may be more sensitive than an IgM, and so it depends very much on exactly which tests are being used. But the reliability of the diagnosis in this circumstance is entirely dependent on the performance characteristics of the serologic tests being employed. And it seems like we're learning every day, as Sanjat reviewed, about the differences in specificity and sensitivity of a number of these assays and different assay platforms. Well, what about retrospective diagnosis? Early in the pandemic, and still today in many settings, persons with mild to moderate symptoms not requiring urgent medical care may not have had molecular testing performed because they were urged to stay away from a clinic unless they really were ill enough to require hospital admission. Many such persons who are now recovered are interested in knowing if they have actually had COVID-19, and a SARS-CoV-2 IgG may be helpful in making that diagnosis. The problem here is that in some jurisdictions, once somebody has a positive IgG, there may be a requirement by the public health authorities to then obtain a nasopharyngeal or oral pharyngeal swab for PCR testing in order to exclude active disease. And that's because with certain platforms that are quite sensitive, IgG may be detected even during the acute phase of illness at a time when the patient may still be infective to others. In addition, many healthcare workers want to know if they've been exposed or have immunity to the virus. Most experience to date suggests that, in fact, a very small fraction of such individuals will actually be positive, and the seropositivity rate depends on the availability and proper use of personal protective equipment. The more available and the more consistently such PPE is used, the better protected the healthcare workers will have been, and the lower the likelihood that they have become infected and would have any antibody. Well, what about back to work? This is perhaps the most controversial area, and I would say that results of serologic testing should not be used as a criterion for determining who can come back to work. This is because the majority of the population around the world is still likely to be seronegative, and I'll show you some data in a moment. Also, there's no guarantee of protection just because you are seropositive or for how long such protection might last. And one cannot emphasize enough that regardless of serostatus, being seropositive is still no substitute for the use of appropriate personal protective equipment, be it a simple surgical mask in normal social and work situations, or more confining PPE in certain healthcare settings. Well, this folds into the discussion of public health uses of serologic tests for COVID-19. And here, the most important use is to perform well-done population-based serosurveys, random sampling of large populations, which are essential for refining our understanding of COVID-19 epidemiology. Of course, that raises the question then of what do you do about those individuals who test positive for IgG, some of whom may have acute infection because of the ability to detect IgG very early on with certain platforms, as I discussed in a few slides ago. But this testing really has no role in determining when to relax social distancing, despite considerable media interest and interest on the part of many government authorities on potentially using antibody testing to tell us when we can go back to work as a society. If current measures have been even moderately successful, the majority of the population is going to be seronegative. And as I've said, seropositivity is no guarantee of protection against reinfection, at least not known to be protective. And the duration of such immunity, if it exists, is uncertain. Just this week, there was a very interesting analysis published in the New York Times using data from several surveys reported independently from a number of cities. And what you can see in the upper left panel here is this is what the situation would be if roughly 2/3 of the population was seropositive. The prevalence of antibody positivity needed to have herd immunity. And shown in the remaining circles is the actual seropositivity rate in various major cities around the world, including New York, London, Madrid, Wuhan, and Boston, where the rates range from nearly 20% in New York to about 10% in Boston, well below the 60% threshold needed to approach herd immunity. So we really shouldn't expect there to be sufficient immunity in the population to allow for return to work. We'll need to return to work with appropriate social distancing, wearing masks, and taking effective measures to prevent the ongoing transmission of SARS-CoV-2. So in conclusion, rapid progress has been made in developing virologic and serologic tests for SARS-CoV-2. These tests have a wide range of sensitivity and specificity depending on the particular platform. Both types of assays have important clinical and public health applications, but assay limitations must be kept in mind when interpreting individual patient results and establishing public policy. And let me end just by acknowledging a number of my colleagues who either provided some data to help my talk or with whom discussions have really helped shape my views on this important topic. And I'll turn this back to our moderator.
And thank you very much indeed. Very interesting. And I'm just thinking that, you know, as a lot of us come out of lockdown, one of our dreams is to go on holiday. So here I am in my shorts with my towel. I arrive at an airport and I'm about to go to a big resort. What sort of testing would you think I should have if I arrived in some country where COVID has been, you know, there's been a seroprevalence of 10%?
I think the best thing you could do would really be to make sure you wear a mask, stay out of crowds, and wash your hands carefully before eating and when going back to your room.
You're the president of this. You're the president of this country. What are you going to do? What would advice you would give to the government for people coming in to do that? What you just said.
Well, you know, I think the problem is you could screen people, but they could be positive the next day. They may be incubating virus and not positive. So I don't know that screening travelers is going to be really all that practical. I'd have two concerns. One is, you know, it's one thing to be doing screens in a healthcare setting, but to have people sitting at airport stations doing nasopharyngeal swabs on thousands of travelers as they transit through, and then putting them into some of the rapid testing kits really worries me. There could be a lot of false positives and a lot of false negatives in that situation.
Okay. Now, what about HIV patients or other immune suppressed patients if they're having these serological tests? Well, has there been any data that there any difference?
Oh, that's a great question. We don't really have any systematic information about that yet. Certainly one would imagine that just as with other kinds of infections, that people with advanced HIV disease who have CD4 counts below 200 may be less likely to seroconvert. And certainly people who have immunoglobulin deficiencies may be unable to seroconvert. And that would even include, you know, people who have had CAR T-cell therapy for lymphoma, who now no longer have their own B cells, may not be able to make antibody. That's a pretty unique subset. We see a lot of those at our hospital. But that would be the group in whom I'd be concerned that antibody testing may be less reliable.
And maybe if you're on rituximab or some other.
Yes.
drug to stop B cell function. Okay. So and just before we get to the round table about healthcare workers, because I'm one, I've got an interest in them, of course. So there's some data from Italy to suggest that healthcare workers did not get infected in the hospitals. It was actually, a lot of them got infected because of the community interactions they had. So one of the problems I see with healthcare workers is they can take extreme precautions at work, but come home and or travel on the transport, come home, etc., and be at risk like everybody else.
Oh, no question about it. I think that healthcare workers are people too, and they have lives outside of the hospital for sure. And that is where the vast majority of healthcare workers are getting infected if they have become infected. That's not to say that there is not the appropriate concern about nosocomial transmission or occupational transmission. But if, for example, in our own hospital setting, something over 3,000 people in our hospital system, workers have been tested. About 12% are positive. That's roughly half the rate of the positivity among all people in Massachusetts who've been tested. And there's been no clustering of cases in the hospitals, suggesting very strongly, as you say, that infection was acquired in the community. That's why it's so important for healthcare workers to be wearing masks, to report symptoms if they have them, and to be tested if they have symptoms. But simply testing blindly is not really going to be a particularly useful public health tool or infection control tool.
No, okay, that's great. So maybe we can continue the conversation a bit now with all of the panel, if you can all come online for the roundtable discussion. I just wanted to ask, Geneviève, are you on yet? Let's see if you're there. Well, maybe.
Yes,
maybe,
she's just back.
Okay.
Yeah.
Hi.
Hi.
Look, I saw from your data, there's quite a lot of virus in feces. So is there any evidence that there's fecal oral transmission? Because, that is a transmission route for lots of viruses. And finding virus in the feces, it sort of concerned me when I saw that data. So can you make me feel happier that fecal oral contamination isn't a route of transmission, please?
Yes, this is a very good question. As I showed, there are some studies that show that we can find some RNA in the feces, but it doesn't mean that this is an infectious virus. And all the studies I've seen did not show that it's possible to isolate the virus from the feces. So I don't think that there is very good data showing that they can have a fecal oral transmission.
Oh, great. So it's just swallowing it and then it comes out in the feces, and it's just how wonderful PCR is at picking up a...
But PCR is so sensitive.
Okay. So
but I think that there is also a question maybe of quantity of the virus. Maybe there is a low quantity of the virus, and that the inoculum is not enough to get an infection for another person. Okay, thanks. So Sanjat and Dan, remdesivir, people are giving this. Well, do you think that's going to affect the antibody response if you take it, or any drug that may be effective? Okay, so what's the thought about that?
That's a great question. I mean, we certainly know that in HIV, if you treat very early, within days of infection, that you can prevent seroconversion. Most people are not getting remdesivir that early because at least current guidelines under the emergency use authorization in the United States limit its use to people who already have substantial hypoxia. In addition to which, it's not so clear that being able to make a serologic diagnosis of COVID-19 is all that important if you've made the diagnosis by an alternative means.
And Sanjay, anything to add to that?
No, I agree. I think the possibility of an antiviral given later in the illness in response to that illness is unlikely to blunt the immune response. So I think I agree with what Dan
And
said.
while you're there, so why don't we have a strategy that if you have a rapid serology test, that you then go on, because it's only going to be a few % of those people you're testing, you then go on to have a neutralizing antibody test. And then if that one's positive, you can say, great, I've got neutralizing antibodies, and I can be a bit more relaxed about the fact that I've had COVID, and maybe I'm, because they're neutralizing antibodies, they're going to be really useful for me if I come across COVID again.
Yeah, it's still a little bit premature to say that. I mean, while we can gain some comfort in knowing that neutralizing antibodies generally confer protection, there are other pathways for immune protection that are outside of the neutralizing antibody response, such as the T-cell response. And so I think, based on our experience with other viruses, yes, it's certainly biologically plausible, but we actually need to prove it, and that will take considerably more time and effort.
Mm-hmm. Geneviève, anything to add to that?
No, I agree with Sanjay. We need more data about the persistence of these neutralizing antibodies to know what will be the duration of these antibodies, and we don't have yet some correlation between the neutralizing titer and the protection. So we need. It's a difficult message because people are happy when we say yes, we have antibodies, so I am protected. Can I have a immunity passport? But no, we cannot say that yet. And if I may, I have a question for Sanjay regarding the rapid test for antibodies, because we have some. We are preferring such tests in my lab, and sometimes we have patients with only IgM on the rapid test. So what would be your recommendation? Do we have to ask for a PCR test for these patients? What do we have to do?
I think my opinion here, everything about test interpretation really relies on pretest probabilities. And so if you have a high clinical suspicion, IgM positive and likely symptomatic, then I will get a PCR test. But if you're low, your pretest probability is low, and say it's a borderline result, so you have a semi-quantitative test and it's right above the cutoff, it's certainly possible to be a false positive, and rather than getting a PCR, I would wait another 5 to 7 days and repeat serologic testing. So everything depends on that prior test probability.
Great. So thanks. Dan, I'm going to put you on the spot now. Right, here we go. So there's a lot of countries in the world, especially say in Africa, parts of Latin America and Asia, where none of these tests are available. So are we going to use symptom-based to say that you are COVID positive? Are we going to do that? I mean, maybe you've got an X-ray, maybe not. But what advice would you give to those docs working and healthcare workers out in the field?
Well, so I think it's really challenging. So first of all, with influenza, which is obviously a different disease, but another viral respiratory infection, during peak influenza season, the presence of symptoms that are constitute influenza-like illness actually has a higher positive predictive value than a rapid flu test, which is only about 60 or 70% sensitive. So yes, you could certainly make the diagnosis based on clinical syndrome. If somebody presented with fever, cough, shortness of breath, and had bilateral patchy pulmonary infiltrates, or on a CT scan had ground glass opacities, that's not the big challenge. The problem is really being able to know who else might be infected and spreading virus, because our experience in the US, where we had very limited access to testing early on, and we were only testing symptomatic people, is we were missing all of the asymptomatic people, and that's what allowed such dramatic spread of the infection, in contrast to some of the countries in Asia that did very extensive testing and managed to dramatically curtail the size of their epidemics. And so clearly access to testing is a huge issue, but because we know that so much transmission occurs at or before the time of symptom onset, from a disease control perspective, testing becomes much more important for prevention of transmission than it does for diagnosis of illness.
Yeah, yeah. And Sandra, you don't think, or Geneviève, that there'll be very, very cheap testing kits that you don't need to refrigerate, that could be easily used in those settings at some stage in the near future?
Yes, for example, antigen test would be a good, for example, a good option if in some places where you cannot implement a RT-PCR test. There is maybe an issue about the sensitivity of this kind of test, but if you are in a situation where the epidemic is very high, with very high viral load in patients, it could be an option. It's very easy to use. So yes, I think we have to find some solution to implement this kind of test. There are also the lump PCR that are very rapid, very easy to perform, and this kind of test I think could be very interesting in such countries where RT-PCR is difficult to implement.
Yes, I agree completely. There's a lot of effort actually going into simplifying this, and part of what we're doing is also validation of saliva, again, as an alternative specimen. And so that would greatly reduce the barriers to testing in resource poor settings. I think we're going to be partnering with some organizations abroad to do this in parallel.
So the other thing that struck me from the data I saw from the first talk, actually, in Geneviève, is the fact that plasma you get a much less positive signal. But I wondered whether the very sick people, the people that have the cytokine storms and everything else, that you will find it in the plasma, and maybe, Sanjay, the antibodies will be abnormal or disturbed or dysfunctional. So I wondered whether either of you got any thoughts on that, that you might be able to predict the people who are really going to get sick, because we do that clinically, obviously, with the oxygen saturations. So I just wondered whether there's any data that you might be able to pick up these people a bit earlier because they're viremic and they've got abnormal or some heightened or some strange antibody response. And you then know you've got to get them ventilated or you can intervene more quickly.
Yes, in my experience in my hospital, we had a lot of patients in intensive care, and this patient had sometimes viremia. The level of the viral load was not very high, and the presence was sometimes inconsistent during the follow-up. But yes, the patients with severe disease tend to have more viremia than patients with mild disease. And we have observed also that patients with severe disease have a higher antibody response and very quickly after the onset of symptoms. And the patients with the mild or very asymptomatic disease have a lower antibody response, and it takes more time to appear during the follow-up. So yes, there is probably a correlation between the disease severity and the antibody response.
Thanks.
Yeah, I think a I think what we're looking for is a biomarker to predict severity of illness. And I have reviewed some data on this. I think it's a little bit challenging now to find something that rises in an early enough time period for you to take an intervention that differentiates, those with mild versus severe. But I agree, there's probably something out there. RNAemia, I don't call it viremia, I think potentially has that. But again, I think we need a little bit more study on that.
Yeah. Okay. So Dan, I'm going to ask you the last thing about children, really, and about children at home with their parents, with their grandparents. A lot of them now are off to school and coming back home. Well, it's natural for grandparents to want to hug their children, etc., etc. Have you got any thoughts about and it's hard to put masks on kids and tell them to wash their hands and do that. I just wondered whether you just have any final thoughts about how we can improve that way of public health prevention.
Yeah, I think that's one of the great challenges right now, because we really don't know what how likely children are to carry a virus back into the household without having any symptoms. The majority of kids seem not to get ill, and that it is a big worry. And I'm not sure there's a real single answer to that.
Yeah, and probably we're doing the experiment right now.
Yeah,
so we'll find out. Well, I would like to thank the panel very much indeed. I've learned an enormous amount, and I hope the audience has. So thank you very much for this round table discussion, and we hope to see you back here soon. Thank you so much indeed. And for all of those of you online, a virtual clap to our guests. So the key points, we've looked at the use of PCR technology for diagnosis, and also about the various means of serology, and that things aren't as clear cut as we know in terms of making positive diagnoses, and also in the use of serology in trying to make people feel relaxed about the fact they've had COVID in the past. And I think that's a dangerous presumption at the moment. And I think one thing I've learned from this seminar is just because somebody's got antibodies, first of all, it might mean they're false positive, and secondly, it may not mean that they're immune to COVID. Dan's gone through a lot of scenarios for us about return to work, and what to do with healthcare workers, and we've answered a lot of questions today that have come up. And I'm really sorry if your particular question we didn't get to, but the questions will be there online. So with that, I'd like to thank and acknowledge Roche, who've supported this with an independent medical education grant. So thanks very much indeed. And we also have a number of people that and organizations that endorse us who are on this slide. So I'd like to thank them very much indeed. Special thank you to our official endorsers. And then we come to you. So I'd like to thank you all for being on this webinar. I hope you've enjoyed it and learned a lot from it today. And you can come to the website. You can see here, www.academicmedicaleducation.com for materials and more information. And finally, please complete the webinar survey after this webinar, because we need to know how we've done today, what things you'd like to discuss in the next webinar. And we've got a tentative date for the next webinar, which is Tuesday, the 23rd of June, 2020. So pencil it in the diary with a question mark, and we'll be confirming that later on. And so I'd like to again thank all the panel and wish you all a wonderful morning, afternoon, or evening, or middle of the night from wherever you're watching. Thank you.
Thank you.
Thank
Thank you very much.